I'm not sure who is best to answer this. Perhaps Mr. Lippman could start out. But the question has come up, I think the two alternatives to expanding Medicaid are not expanding and not accepting expansion, and number two is delaying expansion and hoping for some kind of waiver. And I think those three are the options that are before the commission. I sit on Health and Human Services, and I know how strapped we are across the board in terms of our health care, especially in mental health. But I would ask, what would be the impact, or what will be the impact that you've projected of not accepting Medicaid expansion or delaying Medicaid expansion for 1 to 3 years and giving up the federal grant?
Community at large standpoint, we're going to be paying the federal taxes as a state, and we're not going to be getting anything back. Is one aspect. I think with respect to the choices at hand, I think that the commission has an option of expanding Medicaid now and doing a waiver, but without delay. So, I think it's been either you do expansion or you do a waiver, and that waiver will cause delay. I think a political compromise should be reached on the part of the legislature to do expansion now, because we've got Medicaid managed care starting just about the start of the year. Having two transitions, I think, is a mistake with respect to it. I think moving ahead and expansion is the right course. Without it, we're delaying for a longer period of time the transformation that needs to happen in healthcare in general. That's not just enough Medicaid beneficiaries, but the whole community at large, business and individuals paying their insurance in particular.
Can you give me any sense why it's the only company we have?
We've asked ourselves, I think, the same question, and we've sort of gearing up for this for a year and a half steadily before that in concept, and we assumed there would be others in the exchange. Now, Anthem does have substantial resources. We're part of a larger corporation, WellPoint, at a national level, and I think to gear up and get going required a lot of resources. So I suspect there will be others waiting to see how things roll out for a year, and that the competition will pick up in 2015. I know that products from Howard Pilgrim has gone on record saying they're very interested in 2015. So we'll see what happens. You also know, I guess, that there's a chance for a multi-state plan. That is not eventuated. But it's a hard question to answer. And here we are, and some people say, well, isn't that puts you really in a great position? Well, frankly, we prefer actually to have some competition. So it's very interesting dynamic, and we're going to see how it all plays out going forward.
Could you just clarify for me your observation about the Rule report and the disparity between the private insurance rates and the Medicaid rate? And say it again so I can understand.
It's kind of complicated, but try to simplify here. Excuse me, it's a little bit complicated, but try to simplify. So the Lewin report is looking at expansion versus no expansion, and it makes an assumption about what the rates of the net revenues have come to the providers. And the assumption, I think, is built off of what our rates that exist in the market today commercially, and with respect to how the market is actually moving, with what we're seeing exchange net revenues looking like to providers, and Moody's, as an example, just the credit rating agency just published a report Friday, talked about net revenues declining, meaning that the amount of delta change between, say today it's 250 times Medicare, but they're assuming that the net revenues that we're collecting is based on a base of 250 versus what it's actually looking like on the exchange is closer to 100. And the rest of the market's narrowing down, so hope that addresses.
Can I just make a comment? Can I make the assumption that everyone from the panel will commit to individually answering any other questions that may come from commission members subsequent to this meeting?
Representative, no question.
Thank you for all of you for coming here. It makes me very proud to be a clinician in this state, to hear the local knowledge that people here bring to the work that you've done. I think it's really important work. And certainly it sounds like if Medicaid were expanded, it would be more, to be better ways to address the patient's needs. My question is to the provider groups. And I'm not sure who's best suited to answer it, Ms. Potter, about on access. It seems like I've heard two things. One is that there is access for new people entering the system, and there's a large number of people that are already in the system that you're seeing on the issue that you shared with that. And I'm wondering, do we have a sense of how many people are actually in the system already? Is it large group, we're going to have a smaller number of people than we might expect. We see these people on a regular basis. That's the first. And then the second piece would be on uncompensated care for those who are in the system. What would be the impact that the clinicians in the room would see if they were from Medicaid expansion? From uncompensated care.
I can at least speak from the community health center perspective. So the community health center see 122,000 patients and 35,000 of them are uninsured. And I think answering your question might get back to one question that Representative Sherman had with regard to sort of where our options are. So in the Affordable Care Act, there's sort of two pieces to this. There's the Medicaid expansion, and then there's the marketplace where you can get premium assistance for commercial insurance. And so if we do nothing for the Medicaid expansion, we're essentially leaving the poorest of our poor out of this market. When this was designed, it was not designed for Medicaid to be an option. So in the Supreme Court decision, they upheld the Affordable Care Act, but they gave states the option on Medicaid, not on the marketplaces, but on Medicaid. So we're at sort of this tipping point of making a decision about care and coverage for our most vulnerable people who own 138% of poverty, which is $15,000 a year, about $7.75 an hour. Okay? So that's pretty important, just in terms of the distinction. And you, with your recommendation, and with the general court's upholding that, we potentially could begin as early as January and not lose any of the resources, even if we were to begin in the first quarter. Because in the first 3 years of the Medicaid expansion, the federal government is paying 100%. 100%. So anyway, that's a big piece in terms of the distinction, so I just wanted to say that. So with regard to community health centers, 35,000 of them are uninsured, and 67% live below 138%. So what we know is a great deal of our market is already with patients that we're seeing. So the first act for the community health centers will be in-reach. Who are they seeing now that can get coverage, either in the marketplace or in the Medicaid expansion? And we expect that there is some overlap between the community health center patients and the community mental health center patients because we work so well together. So we expect that there is some, but I think when I was giving my testimony about this sort of continuum of care, the health centers, of course, and any provider would be glad to get a reimbursement. But more important than that is this whole continuum of care, so that you as a patient don't have to negotiate with every provider you're going to. So you don't have to put yourself in front of your primary care provider and say, I'm uninsured, I can't afford the care. And then when you go to mental health, say, I'm uninsured, I can't afford the care. And then when you go to a specialist, say, I'm uninsured, I can't afford the care. You and I, with commercial insurance, don't do that. We look at a provider list, who we can see, and we go see that person. And they take our insurance. But for people that are uninsured, they don't have that luxury. And so the health centers and the mental health centers spend an enormous amount of time on the phone, and they have great relationships with the specialists. The specialists do a fabulous job, but they can't see everyone for no money. So this idea of having coverage for people who are very low income is extraordinarily important to our state. So I don't know if I answered your question, but I'd be happy to also do something offline. And I have actually presented my written testimony, which is a little bit longer than my oral testimony.
Thank you. Excellent and brief reports, which is very helpful, but the content is the most important item. So I really appreciate it. Also, you're leading the reports for us. So I'll end this portion of the meeting and we'll move into the public testimony.